So at this height, there is the PaO2 is 60 millimeter of mercury. And during discussion of regulation of respiration, we have seen that when the arterial PO2, that is equal to alveolar PO2, 60 millimeter of mercury, and then there is prominent stimulation of respiration. And so in normal individual, there is not much difficulty at that level, normal individual. When suddenly exposed, unacclimatized individual, when suddenly exposed to this rarefied atmosphere, there is no trouble. 10,000 feet or so. বুঝা গেল? 10,000 feet or so, there is not much problem. But at 3700 meter, some problems do appear. Irritability also do appear. And at 5500 meter, it becomes hypoxic symptoms becomes severe. And at the height of 6100 meter, that is approximately 20,000 feet. Unacclimatized individual, consciousness is lost. In unacclimatized individual, loss of consciousness. তার মানে আমাদের মতো লো ল্যান্ডার যদি হঠাৎ করে 6100 মিটার বা 20,000 ফুট উচ্চতায় উঠে যায়, unacclimatized individual, and in that case loss of consciousness, individual may not die, but there is loss of consciousness and every chance of death in unacclimatized individual. But with gradual rise, and when it is acclimatized, সহ্য করার ক্ষমতা ধীরে ধীরে সে যদি বাড়ে, then it is possible to go at this height and even height more than this. Yeah. Permanent residence of human beings is at that level. Permanent residence. The acclimatized individuals, that is those who born and brought up at that position, at that altitude, in different geographical sites, and permanent human habitation is possible and is there. Yeah. But a lowlander, it is a maladaptive response. You are going at a distance at that time. বুঝতে পেরেছো? যখন একসময় মাইক্রোফোনের ব্যবস্থা ছিল না, তখন যে সমস্ত জায়গায় আমরা চাকরি করে এসেছি, সেই সময় স্টুডেন্টরা অনেক দূরে চলে যেত, এবং দ্যাট উইল বি বেনিফিশিয়াল, so that our non-musical notes can disturb them. That is scientific, because the intensity of the sound varies inversely as the square of the distance. But during these days, it is not required. So that you can stay in front or go back, the volume remains same. So it is an artificial system, detrimental to your mind. বোঝা গেছে? আমরা যে কথাগুলো বলি সেগুলো শ্রুতি সুখকর নয়। সেজন্য আমি যত জায়গায় চাকরি করে এসেছি, সবসময় স্টুডেন্টরা অনেক দূরবর্তী জায়গায় চলে যেত, যেন আমাদের কণ্ঠস্বর তাদের বিরক্ত না করে। And that was scientific. but you are unfortunate in that sense. The advancements of the science, everywhere the intensity is the same, but it is an old habit. Habits die hard. Maladaptive response. Maladaptive response. Whatever it may be, so that whenever acclimatized, and it is possible to go beyond this, acclimatized, and even can live at the top of the Mount Everest. Mount Everest. Mount Everest. Everest 8848 meter. Meter. বোঝা গেল? An individual suddenly exposed to this atmosphere, unacclimated individual, it is not possible to traverse this distance. But with acclimatization, it is possible to live in this at that height, and there is permanent human habitation. But at this height, even at this height, individual, acclimatized individual, they can even live without supplemental oxygen. Without supplemental oxygen. Because for our existence, we require the PaO2, 35 to at least this is present for our existence. For our existence. For our existence. Yeah. Now, with oxygen, these levels are different. With pure oxygen, if an individual inhales pure oxygen, then greater height, he or she can move greater height with pure oxygen. There is no nitrogen, pure oxygen inhalation. And there are more height, they can move. Suppose it is the air, breathing air with oxygen. Oxygen. With oxygen, barometric pressure 187 millimeter of mercury. That corresponds to height of meter. This meter. And in this condition, the PaO2 is 100 millimeter of mercury. বোঝা গেছে? 10,400 মিটার উচ্চতায় যদি অক্সিজেন কেউ ইনহেল করে শুধু, তাহলে সেই ক্ষেত্রে তার অ্যালভিওলের ভিতরে 3টে গ্যাস পড়ে থাকবে। একটা হচ্ছে অক্সিজেন, আরেকটা হচ্ছে জলীয় বাষ্প, আরেকটা হচ্ছে কার্বন ডাইঅক্সাইড। কারণ নাইট্রোজেন তো দূরীভূত হয়ে গেছে। তাহলে সেই ক্ষেত্রে ওয়াটার ভেপর হচ্ছে 47 millimeter of mercury, and PCO2 is 40 millimeter of mercury. So the remaining part is the PaO2, and it is sufficient. So in comparison to this height, you consider this height is much more, it is possible. And it is 40 millimeter of mercury. 40 millimeter of mercury, that is this value. This value, it corresponds to 13700 meter. 70 meter. The corresponding, it is 120 or so. It is, and in that case, there must be some hyperventilation, and at this distance, 40 millimeter of mercury is possible. And that is sufficient for survival. At 140 And when 14,000 meter, and then loss of consciousness even with supplementary oxygen, loss of consciousness. And so acclimatization has a great benefit in this case. In the air, and at 19,200 the barometric pressure is 47 millimeter mercury. The body fluid will boil, and partial pressure of oxygen will be 0. Theoretical value, because persons exposed to that rarefied atmosphere will die quickly, within seconds. If the individual at a height corresponding to 18,000 meter or so, where there is alveolar partial pressure 20 millimeter of mercury, within 20 to 40 seconds there is loss of consciousness. Now acclimatization is helpful to some extent. When an individual is suddenly exposed in air, in comparison to that who are acclimatized, there is gradually when they are moving, and this acclimatization process, how it is helpful, be understood following the 1,000 meter, and it is the ratio of VE divided by VO2, 20, 30, 40, 50 or so. 6,000 meter, because in air an acclimatized individual, it is the limit, and from this value, if you consider it is intermediate between this, and in an acclimatized individual, from this level there is some stimulation of respiration, and between 30 and the, in case of gradual acclimatization, and there will be much more unacclimatized and acclimatized. You find this figure in Ganong's review of physiology, and it is self-explanatory. This ratio is a pure number. Normal VE, that is the ventilation per unit time. Per minute ventilation is, you know, and oxygen consumption you also know. Minute ventilation normally কত থাকে in resting condition in an adult? You are future luminaries. কাজে তোমাদের এগুলো সব সহজ উত্তর দেওয়া উচিত। যে নর্মাল ভেন্টিলেশন অ্যাডাল্টের ক্ষেত্রে কত থাকে রেস্টিং কন্ডিশনে? হ্যাঁ, বুঝতে পারছো? এটা জানা আছে, তোমাদের জানা নেই? মিনিট ভেন্টিলেশন নর্মালি একজন অ্যাডাল্ট ইন্ডিভিজুয়ালের কত থাকে? হ্যাঁ, মিনিট ভেন্টিলেশন বার করতে হলে কি কার দ্বারা কাকে গুণ করতে হয়? এই জন্য মাতৃভাষা ছাড়া হয় না। হ্যাঁ, বিদেশি ভাষাতেই আমরা কিছুটা দূরে সরে যাই, এই জন্য আরো কিছু হয় না। Minute ventilation is equal to tidal volume multiplied by the respiration rate. If tidal volume is half liter, if it is multiplied by 12, you get 6 liter per minute. So if you take this ratio as 6 liter per minute, in a normal individual, healthy individual, oxygen consumption per minute, কত হয়? অক্সিজেন কনজাম্পশন প্রতি মিনিটে কতটা কনজিউম করি আমরা? হ্যাঁ, তাহলে বলতে পারছেন না? তাহলে ক্লাসগুলো কি আমাদের অর্থহীন হয়ে যাচ্ছে নাকি সমস্ত? হ্যাঁ, বুঝতে পারছো? তোমাদের এই যে পাশ করে যাওয়ার পরে তোমাদের দেখলে আমি ভয় পাই, এই যারা পাশ করে গেছে তাদের দেখে আমি দূরত্ব বজায় রাখি। বুঝতে পারছো যে তোমরা একটা মানে সাংঘাতিক ব্যক্তি। এখন অব্দি কোনো রকম কথা বলতে সাহস পাচ্ছে, তোমাদের বলা উচিত এই ক্লাসে। বেশি রাগাতে চাই না, কারণ কি জানি কেউ যদি ধরে মারধর করে সেই ভয় পাই আমি এই জন্য। বুঝতে পেরেছো? তাহলে এটা হচ্ছে 250 ml per minute. Normally it is you can think the fixed principle of cardiac output. If you can think it in a reverse sense, you will get a value of 250 ml. 250 ml. So 250 ml per minute, that is 1/4 liter per minute. 1/4. So the ratio will be 24. So you should start from this level, in between 20 and 30, this ratio. As it is the ratio of the same unit, then it is a pure number. It is only a number. And whenever this, you see, in this case, an unacclimatized individual at the level of 3000 meter altitude, there is no stimulation of respiration. But when it is much more than there is stimulation of respiration in an unacclimatized individual, because there is hypoxia, and when this hypoxic blood is coming and it is stimulating the peripheral chemoreceptors, carotid body and aortic body, then there is stimulation of respiration. But this respiration is not much sufficient. But when acclimatized, and you get much more of this value, clear? So this is this ratio, and it shows this acclimatization even earlier than this is taking place. Acclimatization process has started on, and acclimatization process is such that then there is development of hypocapnia, fall in the alveolar PCO2, there is development of metabolic alkalosis also. But in this case, there is increased attempt of the nature to increase the alveolar PO2, and there is alveolar gas equation, from which you can find out what should be the value. What should be the value? Suppose as Mount Everest, at the Mount Everest, and it is barometric pressure is 253 millimeter of mercury. And in this condition, and this formula of alveolar gas equation you will find in every book text. This is the alveolar gas equation from which you can find out this value, and it is reduced to, if you reduce this, it will be easy, minus PaCO2 divided by R plus PaCO2 into FiO2 1 by R minus 1. R is respiratory exchange ratio, and it is called correction factor, and this part is also called correction factor, or F. So you can find out this normal value. If you put the normal value, you can get this. What is it is? Now, if you take this normal, but PaCO2 is 40, FiO2 roughly 1 by 5, and R is 8 by 10. 1 by R is equal to 5 by 4. 1 by R minus 1 is equal to 1 by 4. Multiplied by 1 by 4 is equal to 2. So it will depend upon this fraction. And if you consider the case of individual exposed to, that is this Pb 253, and in this case PiO2 will be 253 multiplied by FiO2 1 by 5. You have some value. এটা কত হয়? PiO2 42. So if you replace this value as 42, 40 divided by 0.8, if you take this value unaltered, so you will have a negative value. You will have a negative value. You will have a negative value. So that indicates without acclimatization, it is not possible for the individual to survive. But acclimatization do take place. So that whenever there is increase in ventilation, then there is reciprocal shortening of the value of P capital A CO2. Suppose it is when it is more than 5 times or more, 8.0 divided by 0.8 or so. So 44 minus 10, 34. বোঝা গেল? Hyperventilation হচ্ছে. There will be reduction in the partial pressure of carbon dioxide. And suppose you take these values are representative only for understanding, and with the same formula you can get a value of 34. And there is also change in this, where there is some change in this case. It will be 1 or so. I am taking 2 for simplicity. It becomes 1 or so in that case, because there is reduction of this value, and there is it will be 1 or so. It is 33. And when it is 33, it is sufficient for the individual to survive for a short time. short time. And so this is the process of acclimatization. First is, one is hyperventilation. Hyperventilation. But the acclimatization process also involves other parts. And there is increase in the RBC formation. Due to liberation of erythropoietin. When an individual goes up, then there is prompt increase in the erythropoietin. And in that case, the figure we have done, that is this acclimatization at least requires 4 days or so. Because with days, then the pH of the brain fluid or CSF becoming normal. There is increase in the hydrogen concentration due to lactic acidosis or transport of hydrogen from outside to this, or loss of bicarbonate, whatever it may be. Then there is the stimulation of ventilation. Initially there is less stimulation of ventilation and it takes 4 days at least. Now with this there is increase in the erythropoietin, prompt increase. But with acclimatization, level to some extent is reduced. In spite of that, there is some elevated level and it takes some time, because the RBC formation is relatively slow process. 2 to 3 days is required to increase in the RBC concentration. And increased RBC concentration or increased hemoglobin level is beneficial. At the same saturation, more oxygen it can contain. Along with the process of, there is the acclimatization within days, weeks, months, there is some change in the tissues. Within the tissues, there is in the muscle tissues, there is increase in myoglobin formation. Increase in the number of mitochondria and increase in the level of the cytochrome oxidase enzymes. Vascularity will increase. All have their beneficial effect. So this process of acclimatization is that the individuals living at high altitude has 55,000 acclimated acclimatization, where this the PaO2 is 45 millimeter of mercury or so. They are polycythemic. They have barrel-shaped chest and they are otherwise normal regarding activities. Their sensitivity to hypoxia is to some extent less than lowlanders. Lowlanders, when go to top in adult age and live for considerable length of time, its sensitivity does not diminish. So it is set point is ready in early life. This is acclimatization. So it is some part of this hypoxia, and how the acclimatization process can help an individual to live even at the high altitude Mount Everest, at least for some time. With oxygen there is no problem. He can scale 10,400 up to the even there is the partial pressure of oxygen remains normal. And without oxygen, when the atmosphere is good and barometric pressure is more, then it is possible to live for some time at that highest level. This is a remarkable coincidence that the top of that is the height of our living surface is sufficient for survival for some time. And nature is kind. It does not want that its creations will die due to her fault, nature's fault. Yeah. So, next 1.5 hours we can discuss with the renal physiology side by side, because time is short. Within this time we have to consider the renal physiology, and after few days respiratory physiology will end, and then we continue with the renal physiology only. And during your examination time will appear, then you will be prepared. আমাদের দায়িত্ব হচ্ছে যে তোমাদের মিনিমাম ইনফরমেশনটা দিয়ে দেওয়া এবং তোমরা বই থেকে এটা পড়ে নিতে পারবে। খুব সহজ সাবজেক্ট ফিজিওলজি, খুব সহজ সাবজেক্ট, বই থেকে শুধু পড়ে নেওয়া। তারপর তোমরা নিজেরাই বলবে আমাদের কোনো সাজেশনের দরকার নেই, আমরা পরীক্ষা দেবো, আপনারা শুধু প্রশ্ন তৈরি করে দিন আমাদের। এমন দিন আসছে। হ্যাঁ, ওরা প্র্যাকটিক্যাল ক্লাসে আমাকে বলবে যে স্যার আমাদের কোনো সাজেশনের দরকার নেই, আমাদের যথেষ্ট তৈরি হয়ে গেছে, আমরা নিজেরাই লিখতে পারবো। Functions of the kidney is that it maintains homeostasis. It is the principal excretory organ. Huge amount of blood, rather plasma, it is filtered in it, and it has a good number of tubules, and they have their effect. They can reabsorb, that is the important elements, and they have the capacity to secrete it, so that the homeostasis is maintained. Other organs have excretory function like intestine, skin, but kidney is important, essential organ. And kidney is also an endocrine organ. It can liberate a good number of hormones. If not good number, some number of hormones. So it is an endocrine organ. Endocrine organs. And the kinins, calcitriol, renin, erythropoietin, they are secreted from the kidney, endocrine organ. Now if you compare the composition of plasma with that of the urine of some elements, it will be clear. It will be clear that it has what it has to do. Suppose in case of plasma, urine and plasma. Suppose in this case, consider the case of glucose, milligram per deciliter or so. In the urine there is normally no glucose. পিছনে একটা থাকলে ভালো হতো, আপনার তাহলে সেখান দিয়ে চলে যেত, এখান থেকে পিছন দিয়ে চলে যেতে পারত। কালক্রমে সেরকম হবে, যাতে সেটা কোনো দিয়ে চলে যায়, বুঝতে পেরেছি? এই সমস্ত কুবাক্য শোনা উচিত না। হ্যাঁ, ইয়ার প্লাগ দিয়ে বসে থাকবে, সে টাইমটা পার হবে। বইতে সব লেখা আছে, এভরিথিং রিটেন দিকে। তোমার বলবে যে স্যার এইসব সহজ জিনিস আপনারা এসব ক্লাসে আলোচনা করছেন, এটাতে আমরা মানে লজ্জিত বোধ করছি। আপনারা শুধু প্রশ্নটা দেবেন আমাদের, তারপর দেখবেন আমরা কি লিখি। এমন দিন আসছে প্র্যাকটিক্যাল ক্লাসে আমি শুনতে পাবো, তোমরা অনেকে গিয়ে বলবে আপনার পড়াশোনা নিয়ে চিন্তা করতে হবে না, আমরা এমন লিখবো আপনার দেখবে। আমরা তো অনেক ইমপ্রুভ করে গেছি। হ্যাঁ, তোমার বলবে, শিগগিরই সেদিন আসছে। নাও milligram per deciliter glucose in the urine, there is normally no glucose except in diabetic individuals, but in normal individual it is 100. Suppose in case of glucose, suppose it is urea, milligram per deciliter. Plasma it is 15 and even it is 900 urea. So it is an excretory product primarily metabolic end product of nitrogenous substances. How urea is formed, in which organ or so, it is the domain of biochemistry. But in spite of that, we have to know something. Suppose it is creatinine, milligram per deciliter. Suppose it is 150 and it is 1 or so. In case of sodium ion, milli equivalent per liter. Normal concentration you know. In case of plasma sodium, milli equivalent or millimole per liter. এটা সবারই বলা উচিত। কে বলবে? তুমি একদম যে কর্নারে আছো, তোমার কত রোল নাম্বার? একদম কর্নারে, হ্যাঁ, কত রোল নাম্বার তোমার? হ্যাঁ, 121। তোমার রোল নাম্বার চাই, তাহলে কত হবে? সোডিয়ামের কনসেন্ট্রেশন প্লাজমায় নর্মালি কত থাকে? হ্যাঁ, এটা কেউ বলতে পারছো না? এটা তোমার রোল নাম্বারের কাছাকাছি তো, আছে এটার কনসেন্ট্রেশন। হ্যাঁ, বলতে পারছো না? তাহলে হ্যাঁ, মনে নেই? তাহলে এটা মনে করো, এটা হচ্ছে and it is, suppose it is 90 per 90. So these are the values. You can remember. When you go through this, it may be difficult. When you go through all the chapter, then your concept will be clear. Then you can remember this. Suppose we are in the balance. Sodium balance. That is, input is equal to output. Input is equal to output, and most of the output is through the kidney in case of sodium. Some amount of lost in the sweat, but that is negligible. And in this way, you can remember what is the amount that is eliminated in the urine, sodium ion, and corresponding sodium chloride, and what is the urine formed. Then you get in this unit what should be the concentration. So when you proceed, when you read, gradually you will acquire this knowledge. Now, and this is the function of the kidney is due to the function of its functional units. This asked in the examination is the nephron. In higher secondary course and even school books, they contain these nephrons. Number of nephrons in human beings and per kidney. Nephron. And in the higher secondary text, you know the structure of the nephron. It consists of a ball-like structure, capillaries. It is called glomerulus, and it abuts into the Bowman's vesicle, renal tubule. Individual renal tubule and this glomerulus, they form a nephron, renal tubule. And when the kidney is sectioned, kidney is a bean-shaped structure, and it can be sectioned, and you will see the cortex and medulla, outer medulla and inner medulla, and the pyramids, they open into the minor calyces, and cortex contains all the glomeruli. That is the cortex. Suppose it is the cortex. It is the medulla, pyramid-like structures, and it will open. Renal tubules will open. It is the cortex. It is the outer medulla, inner medulla. outer medulla and inner medulla, and they open into this inner medulla. Renal pyramid. Now in the cortex, there is the glomeruli, which are formed by the afferent and efferent arterioles. And this is Bowman's capsule, from which there is initially there is convolution, and we are drawing a juxtamedullary nephrons, cortex and outer medulla, and it is the state part, and then it becomes this narrow part, loop of Henle, and it will go distal, and when the distal and they go, and ultimately it will go in this angle, and that is the macula densa, and from which the distal tubule will arise, and they will communicate, then they will coalesce to form the collecting duct, and it will dip down. They open into the tip of the pyramids, and this is the basic structure. Their arrangement is this. You see the textbook and have the concept. Maximum of the nephrons are called cortical nephrons, and juxtamedullary nephrons is 15%. 15% are juxtamedullary nephrons. And we have drawn this nephron. And it is the glomerulus, and it is an afferent arteriole, and then there is a complex capillary network, and they are drained by the efferent arteriole. And from the efferent arteriole, if you take a different color, it is the afferent arteriole and slightly smaller efferent arteriole. And from efferent arterioles, then there is the it then return and interlobular vein and venous system, peritubular capillaries, efferent artery, peritubular capillaries, and in the juxtamedullary nephrons, they also form long loops. This is called vasa recta. Histology text, anatomy text describe in detail, but physiology text only give the salient points, and that is sufficient for us to understand what is going on. Suppose in case of the proximal convoluted tubule, it is a Bowman's capsule, and from this there is the filtration. There is the filtration of fluid through these glomerular capillaries into the Bowman space, and after that it is a neck part, and it forms the proximal convoluted tubule, PCT, proximal convoluted tubule, and it is a convoluted part, and after that it will give rise to loop of Henle, descending and then ascending, and it is converted, it is then ultimately end at the macula densa, at the junction between the afferent and efferent arteriole of the originating nephron, glomerulus of the originating nephron, and then there is the distal tubule, distal tubule, and distal tubule will converge into the collecting ducts. They unite to form the collecting ducts, and it will go in this way, collecting ducts. Duct of Bellini, and in this way they open into the minor calyces, major calyces, renal pelvis, and ultimately by the ureter urine is going on. Collecting tubule or collecting duct. Proximal convoluted tubule is very important. Very important. They consist of cuboidal cells and they bear microvilli, brush bordered. They are brush bordered. They bear microvilli that increase their surface. Proximal convoluted 15 millimeter length. 15 millimeter length, 5 millimeter is the diameter. Excuse me, there is the 15 millimeter length. Diameter, the unit I have forgotten, you will find it is micrometer or so. And in this case, the cells they have connected at the apical junction border, and they connect to the neighboring cells, and there is this is type of structure, nucleus, and this increases the surface area, and it is the principal site of reabsorption of water and other substances. Proximal convoluted tubule. And when and in the loop of Henle, they are composed of thin cells, squamous type of cells, thin cells in the lumen, thin cells. The descending limb, ascending limb, these are thin cells, and the descending cells are not fenestrated, but the ascending limb, the cells are fenestrated. Fenestrated means there is gaps between them. Suppose whenever there is fenestration, and then there is the gap between the cells, pores or fenestrations. There is attenuation of the cytoplasm, fenestrated. Fenestrations. 70 to 90 nanometer is their dimension. But in this thick ascending limb of the loop of Henle, and in that case it is cuboidal, but brush border is seen only in the proximal tubule. In the distal tubule, they have some microvilli, but brush border is not formed, and their basal surface is indented in this way, and they increase surface area, and they provide space for the mitochondria, numerous mitochondria. And collecting tubule, these are the cells, they are cuboidal or columnar, and there are, and everywhere there are some structural and functional subdivisions also. Suppose in collecting tubules, there are two types of cells, P cells and I cells. P cells means the principal cells. Collecting tubules, the P cells, or principal cells, and also I cells, intercalated cells. And they are histologically can be differentiated. In the P cells, the organelles are less, relatively clear, and their function is water, that is the water reabsorption, and the sodium reabsorption, principal cells. And intercalated cells, and they are more numerous, there are intercalated cells also, and these cells, they have more microvilli, more vacuoles, more mitochondria, and their function is the hydrogen ion secretion and bicarbonate reabsorption. Hydrosecretion and bicarbonate reabsorption. Interstitial cells, two types of cells. So these are these, and their length, collecting tube are 20 millimeter in length, and total length is 45 the tubules 45 to 65 millimeter. Now we have to know something about these glomerular capillaries and this arrangement of this epithelium, arrangement of this visceral epithelium of the Bowman's capsule, and it is fenestrated, and again it is a fenestrated glomerular capillaries, and they are arranged in such a way that is this, suppose it is the endothelium and it is fenestrated endothelium, and there is a common basement membrane, there is some basement membrane, and then this epithelial cells, they are called podocytes, and they give rise to this type of processes from the cells. Food processes, they interdigitate with other cells also. Podocytes, and they interdigitate with neighboring cells. Food process of neighboring cells, and there is a slit between them, and in this case they are fenestrated epithelial 70 to 90 nanometer in dimensions, and there is the podocytes, and in between there is the common basement membrane, and there are mesangial cells in between the basement membrane and the endothelium. Mesangial cells. They are similar to pericytes found elsewhere in all the capillaries. Pericytes, similar to pericytes. And there is a space between this. There is the space between the pedicels, food processes, is 25 nanometer or so, and they are closed by thin membrane. There is no visible pores in this basement membrane, and there is the process of filtration, and that is the rate is much more, 50 times more than capillaries elsewhere as in skeletal muscles. And how it is possible? Because in this case, it is the afferent arteriole and it is the efferent arteriole, and it gives rise to peritubular capillaries, and capillaries ultimately drain to the interlobular vein, then arcuate, then there is arcuate vein, interlobal vein. In this way, they return into venous system, and in effect, and it is a portal system. But in this case, it is not the veins as such, but it is the arterioles. But these arterioles contain relatively less smooth muscle. In spite of that, it has important function, and it maintains the pressure. That is between the beginning of the glomeruli and to the end of the glomerular capillaries, there is only 1 to 3 millimeter fall in the pressure. So there is a high hydrostatic pressure in this case, and there is responsible for this filtration. Huge amount of filtrate is produced. And the mesangial cells, they have their important roles. They can contract, and they are present between the endothelium. It is the blood space, and it is the urine space. And they have a contractile mechanism, and they are positioned suitably in between two capillaries. There bears a common membrane, and in this way, when they contract, they can constrict some blood vessels, they can divert the blood, and in this way, they can have their effect in the filtration process. Normally, huge amount of filtrate is produced. 125 normally in young adult male it is 125 ml per minute glomerular filtrate that is produced. It contains all the elements except the colloids and cellular elements, and per day 180 liter per day this filter. And urine form is 1 to 1.5 liter per day only. So the rest amount all are reabsorbed, and it is required for the elimination of all the wastes, And glomerular, the afferent arterioles arise from the interlobular arteries, so the pressure is relatively more than in other types of capillaries, muscle capillaries, skin capillaries. Pressure relatively more.
This is a gross feature, whatever you are seeing here, present in the scrotum sac is covered with this covering. So whenever you are cutting this particular testicles, it shows some layers. So outside to inside, it has some layers. So most outside we have a layer, which is a serous layer or kind of glistening layer. So this is the most outside layer. We call them as tunica vaginalis. Now you see that tunica vaginalis have got two coats, outer coat and the inner coat. So parietal coat, visceral coat. In between we have a space. So if you have a fluid accumulation which happens over here between this parietal layer and visceral layer of this tunica vaginalis, we call them as hydrocele. So which is a gross topic, I am not going into it, but it is of concern for clinical examination. We see these things coming on as a case when you are studying. So this particular cross sections of this particular testicles, as you see, it has the upper pole, it has a lower pole. Upper pole is identified by the presence of this particular vas difference which is moving up, and on the it has two sides which is like a lateral side and medial side. Medial side have, if you see the cut section, it shows some space which is sinus, just like kidney we have the sinus, and it is occupied by kinds of network of these particular tubules. We call them as rete testis. Now on this side, opposite side, which is the medial side, this is the lateral side, you see a structure which is taking a covering over here, which is that like the layer which you are seeing here, and this is like the collections of the rete testis forms a network of this tissue, we call them as epididymis, which has 3 parts or 4 parts: head, neck, body and tail, which moves down as a vas difference. Vas difference goes up into the inguinal canals, superficial ring, deep ring, and gets inside this back side of the urinary bladder, joins with the seminal vesicle, forms the ejaculatory duct and empties into the prostatic part of male urethra. Now you see that this is the outer layer which is known as processus vaginalis. Then we get a white coat, we call this as a white coat tunica albuginea. So this is the second layer which is having that most of the structural substance present to it. So this tunica albuginea is splitting into several septa. It has some strias which is running from this like a middle region, we call them as mediastinum, to this particular periphery or the margins, and splitting it into small chambers. We call them as lobules, small lobes or lobules. Now each of these particular lobules is occupied by some network of these particular tubes which you are seeing here. So this particular region which you are seeing here is occupied by these tubes, we call them as seminiferous tubules. So this is a hallmark of structures of things, which is a gross you are seeing here. This is a gross feature. Now we have to cut through these to see the microstructure. Whatever the things is present inside to this particular tubules, that's the point of concern for us, which you are going to look in the microanatomy. So coming back once again, we have the layer, outer layer, parietal layer, then we have this which is tunica vaginalis, which has got 2 layers, parietal layer and visceral layer. In between you have a potential space, which if it is occupied with large amount of the fluid, we call them as hydrocele, that the disease which is happening in some of the cases. Then we have this particular second coat of this tissue, we call them as tunica albuginea. Albuginea, it looks like white, that's why you call them as albuginea. Alba means white, you know by this time. So tunica albuginea, it's split into some kind of chambers within it, we call them as lobules. And inside to these particular lobules, we have a coat of vascular structures. We call them as tunica vasculosa. So these are the 3 layers which is present. Outside to inside, tunica vaginalis, then tunica albuginea and tunica vasculosa. Vasculosa is lining inside of this small chambers which is present inside to it, which is known as the testicular lobules, which is present inside. So this is how this particular orientations of this particular gross structure of this testicle is present. So this is how it is going and coming here. So all the seminiferous tubules is fitted within this particular lobules which is present inside, have a straight tube ending on it, like this is straight tube ending on it, and then forms a network of tissues. This is a looking like network, right? So this network of tissue we call them as rete testis. The rete testis joins together from different parts, we call them as efferent ductules. They joins together to form this particular epididymis, which is again supercoiled tube, which is coming in the head, body, neck, tail, etc., and getting inside to it. Getting inside to it, it is coming over here and moving up as vas deferens, which is going as the content of the seminiferous tubules. So this is a structure, whatever the things is present within this particular testicles there. So 3 layers, outside to inside, albuginea, vaginalis, albuginea, vasculosa. This is how these thickened layers are there. All right, and from this particular medial side, we have this particular mediastinum. We have this fibrous thin septa separating this particular region, dividing into testicles into many compartments. We call them as lobules. Each of the lobules contains coils of this particular tube. We call them as seminiferous tubules. Now this seminiferous tubules is our microstructure to study. So we are going to study this microstructure which is present as a content of these particular areas, which is known as the seminiferous tubules. So once you cut this particular seminiferous tubules, the microstructure makes visible or gets visible to us. So we have this particular tunica vasculosa which is present inside to this particular tubules which is present inside. Now then we have this particular structure which is ending in it, seminiferous tubules. If you cut this seminiferous tubules, if you take this seminiferous tubules one at a time and cut it, we are going to see this things looks like a circular structure. Within this each of the seminiferous tubule, we see a lumen present. Now this particular lumen is occupied by 2 kinds of cells. One kind of cells is spermatogonic cells. That means they are producing the sperms or they are manufacturing the sperm series. So whatever the thing sperm is like different phases of the sperm, they are present. They are coming from bottom to the lumen side. So bottom side cells which are immature sperm cells or spermatocytes, etc., and spermatids which are more matured form which are present within these lumens. So these are the spermatogonic cells. That means they are sperm cells. That means they are coming from here and getting housed over here. To support this sperm cell, to give nutrition, to give environment, we have support cells of the sperm cells. We call them as support cells of the spermatogonial cells, which is known as sustentacular cells. So these cells which is present in the support cells, we call them as Sertoli cells. This Sertoli cells is amorphous, do not have any particular shape. It's kind of like a block shaped, have a oval nucleus at the base region and have got processes which is running on different directions. So we have 2 basic types of cells within this particular seminiferous tubules which is coming from here. So seminiferous tubule present in here, we are cutting the seminiferous tubules and zooming it and seeing what is present within this particular seminiferous tubules. Within this seminiferous tubules, we are going to see 2 types of cells. One types of cells, spermatogenic cells. There are different genera of cells are there, and again support cells of the spermatogenic cells. We are known as support or nourishment cells, which are known as the Sertoli cells. Now outside to this particular seminiferous tubules, we see some of the cells which is present. So in between 2 adjacent seminiferous tubules. So for example, one seminiferous tubules is there. Another seminiferous tubules is over here. For example, in between these 2 seminiferous tubules, outside to it, we see some of the cells clustered here. So these particular cells which is present outside, we call them as outside seminiferous tubule cells. They are known as Leydig cells. They are also kind of like cells which are also have got different functions. So we will be focusing on these 3 entities. First, seminiferous tubules. Cut this, see the lumen and different types of cells, spermatogonic cells and the support cells, Sertoli cells are there. And outside of these particular seminiferous tubules, we see these cells, we call them as Leydig cells, which is present outside the lumen. Alright. So we will be focusing on these entities about these particular cells. So talking about the spermatogonic cells, as you know, these particular things is going to produce the sperms. They are of different variety, immature to mature varieties, they are coming up. So spermatogonial cells, they are coming with these particular cells which is known as spermatocytes, sperm teeth, spermatozoa, etc., etc. They are coming up. So more the immature, they are present on the basal regions of these tubules. So they are present on the basal regions. More they get mature, they come to the lumen side. So from the base to they are going on the lumen side. Now this particular seminiferous tubules are present on a rounded structure which is known as basement membrane, which is lying on the basement membrane, and this particular support cell, Sertoli cells, which are present within these particular regions. Now talking about the cells which is supporting the spermatogenic cells, they are known as Sertoli cells. The functions of the Sertoli cells give to provide the nutrition, they secrete the protein substances, they give enough nutrients to this particular region, they secrete the protein substance which is important to us to know, which is known as androgen binding protein, which is known as ABP. Androgen binding protein is an important protein which helps to catch this particular testosterone which gets into this lumen. So if you do not have this androgen binding protein, the testosterone won't be present as a concentrated material within this lumen. So if you do not have the testosterone within this particular environment, this growth of this particular spermatogenic cells will be at stake. It is not going to grow. So that's ABP, which is important for us to have this within this, which is secreted by this particular Sertoli cells. In addition to that, it provides the nutrition and provides the microenvironment, because this is kind of like a cells which is also a defense cells. If something goes wrong within this, these things works as a phagocytic cells as well. It maintains the ionic balance. That means in short, it maintains the internal homeostasis. That means the balance which is required to have the inside this particular lumen, so that the sperm productions can be produced with stimulations of the hormones, and this particular hormones which is known as testosterone need to be present inside as an environment. So that hormone kept with a high molecular level so that this doesn't come outside. So this androgen binding protein holds that particular protein substances which is known as the testosterone or dihydrotestosterone, stays inside the lumen, and this particular region which is this particular spermatogenic cells gets appropriate amount of hormone for the growth, and in addition to that it secretes the protein substance along with gives the nutrition to these particular regions of the spermatogenic cells. So these are the functions of this. Out of this, this is the important functions along with this particular phagocytic functions. Secretes androgen binding protein, in short we call them as ABP. Have this particular other element which is known as this interstitial cells. So you see that this is one seminiferous tubules, this is another seminiferous tubules. In between them we have seen this particular island of clustered cell which is present, making a delta kind of shapes. So these cells we call them as interstitial cells. These are the cells which is present outside seminiferous tubules. So whenever you are going to see the microstructures, this is a microstructure of things which you are seeing here. So this entity is a seminiferous tubules, and this is a boundary. Now in between them we have this particular intermediate area, where this particular area we see some of the cells which are clustered over here. So this cells which is present between these two seminiferous tubules is known as interstitial cells. The leading interstitial cells are the prime functions which having the here is secreting this testosterone, which is eventually converted into dihydrotestosterone by some hormones or by some enzymes into active component which stays inside. Once this thing is liberated, that gets inside to this particular thing through circulation and stays inside, held by ABP, and so that this particular testosterone or dihydrotestosterone stays inside this particular lumen. So this interstitial cell or interstitial tissue which is present outside the seminiferous tubules. So once again we have this particular three things to consider over here. This is a cross sections of these particular testicles split down into lobules by these fibrous strands. They are present within these lobules, seminiferous tubules. We take each lobules in a time, take a cross section. Inside the lobule we see two types of cells. One is spermatogonic cells, other is the supporting cells which is known as Sertoli cells. Spermatogonic cells are of different phases of the spermatogenic phases of maturations are there. More immature cells are present on the basal side, and mature cells present on the lumen side. Sertoli cells are the cells which are support kind of cells. They are having some kind of process. This particular Sertoli cells with the process, they make a network of the cells or make a network kind of things, so that this particular network serves a function. We will coming into it. So this particular Sertoli cells secrete some kind of like a nutrient element, it secretes some kind of protein element. they hold this particular internal environment, and if we require, they work as a phagocytic cells. So this particular Sertoli cells, which is kind of like important for us, and functions of it we have to know about. Spermatogenic cells which are present within this particular region, and they are present on different forms, starting from spermatocytes to mature form spermatozoa, and eventually the sperm are stored into the epididymis. So this particular region, you see that sperms are produced from the seminiferous tubules, which are gradually getting matured, runs to these retrotestis, and eventually gets stored within this particular lumens of these epididymis, and then when it is required, it is ejected out through the vas deferens and subsequently to the exterior. Now, other functions of this particular Sertoli cells. Now, we are talking about this particular Sertoli cells. They are kind of amorphous cell, doesn't have a proper shapes. This particular amorphous Sertoli cells have got processes which runs in different directions and joins with adjacent kind of like Sertoli cells processes. Now, by making this, they split this particular internal environment of these seminiferous tubules into two components. One is inside, we call them as luminal components. So this is a lumen side and this is a basal side. So they split this particular element into two components. This is a basal side of this particular seminiferous tubules, and this is luminal side of this particular seminiferous tubules. So from this particular basal side, that cell, once they get matured, they move into luminal side. So these processes, which is made by this particular Sertoli cells, which is housed on this particular basement membrane, they make a kind of barrier mechanism. We call them as blood-testis barrier. So this blood-testis barrier is a kind of structural unit which is present within this particular seminiferous tubules, which is lying within it, the cytoplasm formed by the cytoplasmic process of these particular Sertoli cells, which runs in horizontally, which runs transversely, joins with each other, and this particular processes, which is resting on the basement membrane, separates the blood vessels from this lumen interior. So the blood is not getting inside this particular seminiferous tubule lumen, neither this particular substance, proteins, Siemens, which are leaked from this particular lumen to this particular exterior blood vessels. So the exchange of the proteins or these particular elements are cut down by making of this particular blood-testis barrier. So if you have a disruptions of this blood-test barrier by the destructions of these seminiferous tubules, by destruction of the Sertoli cells to be specific, we have a loss of blood-testis barrier. So if you have a blood-testis barrier loss, that means the blood which can escape into, and this particular proteins can escape into the blood system. So if these things happens, we have these particular things which is the Siemens and this particular proteins which is present within this particular sperms that is developed after we are reaching to an age which is known as adolescent age. So this particular element which is maturing at the adolescent age, the proteins and everything, which is foreign to us, because the immunity which we are getting is which is developed when we are born or just nearly born, first or second years or third year of life. By the time we get exposure to all kind of immune substance and we develop an immunity. So if we have a late exposure of any body protein which is the immune system is not very exposed of, we generate autoimmunity. So to stop that, this particular blood-testis barrier was relevant and important, or else if you develop an autoimmune antibody against the sperms will be destroyed. So that's why this blood-testis barrier is immensely important. So in some of the diseases, say for example mumps or any kind of viral diseases which is basically breaching this particular blood-testis barrier. So in case of the mumps, we have orchitis, that means this particular epididymis is inflamed by this particular viral infections. We may have a trauma which may be just like penetrating this particular traumas, penetrating this particular blood vessels and mixing up with this particular element. So that exposes us with this protein substance which is not exposed by us before this time of born, before we are born or immediately after we are born. These proteins will be exposed to the blood system and then we have an autoimmunity generated. So that particular autoimmunity, if it is generated, we may have these destructions of these particular late developing substances which may happen in case of some of the diseases. So that can lead to the infertility or any other problems. So that's why this particular blood-testis barrier and the clinical role of this particular thing is important. So in physiology, we see that this particular blood test is barrier formations and the significance several times tested in examination. So you have to know about who is making this blood test barrier, what are the functional utility, and if you lose this blood test barrier, what happens to it. But in a physiology or in anatomy, we focus in this microstructure. So this is what you are seeing here, the microstructure of the testis, which is seminiferous tubules in a focusing. We'll be seeing this seminiferous tubules, which is rounded cells. These are the areas which is seen here in a higher magnifications, and this is how what it looks like normal magnifications. This is normal magnification. This is how you are going to see. Whatever you are going to see here, we have to focus here this particular tubule. So you will be seeing plenty of the tubules. That's the thing you have to see. There's plenty of tubules. That means there is a cut end of the seminiferous tubules, which is showing interior to it, has the lumen inside and spermatogonic cells and supporting cells present inside. Outside these tubules, we have this particular interstitial cells, which is interstitial cells of Leydig are present, which is also visible, which is secreting the hormone, which is testosterone. So these are the identifying feature of this testis or microstructure of testis. Now this is one of the highly tested slide in examination. We give this particular slide for identifications in any form of examination, be it undergraduate, be it postgraduate. So this is one of the things we must identify properly, carefully whenever you are coming to it. So we have placed some of the slides, some of the specimen we have, go through it. I'm coming to just focus on him.
What is mediastinum? We know in the thorax or thoracic cavity, there are two lungs, and in between the two lungs there is heart. Okay. Now the lung is covered with some membrane, which is called the pleura or pleural membrane, which has got one intimate layer which is attached with the lung tissue, that is called visceral layer, and another is the outer layer which is called the parietal layer. And in between these two layers, suppose this is the visceral layer and this is the parietal layer, we know that is the pleural cavity. Okay. So this parietal pleura is divided into different parts. One is covering the apex of the lung, apical pleura. One is covering the costal surfaces, there is the costal pleura, and in between two and a space which is covered inside, that means covering the heart, that is the area which is called the mediastinal pleura, or this one. So this one is the mediastinal pleura. So what is mediastinum? Mediastinum is nothing but a space in between two mediastinal pleura. Okay. So this is the mediastinum, and that mediastinum is bounded in front by the sternum, behind by the vertebra. Okay. In front there is the sternum and vertebra, and the whole thoracic cavity we know is, it starts from the first dorsal vertebra to that 12th dorsal vertebra. Okay. So this is the inlet of the thorax. Above the inlet we will get the neck, and below it is covered with this is the area, this is the T12 or the 12th dorsal vertebra, and here we get the lower limit is limited by the diaphragm. Okay. So this is the area, so this is the whole area, and in between the two lungs, or safely we can say that is in between two mediastinal pleura, this is the mediastinum. So extent of the mediastinum, we know the thoracic inlet, and this is the thoracic outlet. Now this is the sternum, this is the manubrium of the sternum, then we are getting the body of the sternum, and this one is the xiphoid process. Okay, and xiphoid process is of various shape and size. Okay, now if we make a imaginary line in between the manubrium and the body, then that imaginary line will pass through the lower border of the T4 vertebra. Okay, and this imaginary line actually passing, this is the sternal angle. The sternal angle means the junction between the manubrium of the sternum and the body of the sternum. This is called the sternal angle. So a line which passes through, horizontal line passes through the sternal angle, okay, or a knife, suppose a knife is passing through the junction between the manubrium and the body, it will pass behind, just below the T4 or thoracic 4 or dorsal 4 vertebra. So now this area is a space, and below this area there is another space. Okay, so this space is above this area, above the sternal angle. Okay, the horizontal line passing through the sternal angle, this is called the superior mediastinum. Okay, and below this line or below this plane, we are getting an area of the thoracic cavity, that is the inferior mediastinum. এই জায়গাটা পরিষ্কার হতে হবে. So superior mediastinum is an area of the thoracic cavity above the plane passing through the sternal angle and behind, just below the T4 or thoracic 4 vertebra. So that area is the superior mediastinum. Below this area and up to this, the dome of the diaphragm, this area is called the inferior mediastinum. Clear? Again, this inferior mediastinum is divided into 1, 2 and 3 parts. 1, 2 and 3 parts. This is the area, this is the pericardium, and within the pericardium, this is the heart. So this outermost layer is the fibrous pericardium, and within which we are getting the 2 layer of serous pericardium, and inside we are getting the heart. The pericardium, which is intimately attached with the heart, is the visceral layer of the serous pericardium, and that area is again reflected, and we are getting a cavity, and this lining is called the parietal layer of the serous pericardium, and most outside, this is the fibrous pericardium. You must know this fibrous pericardium and diaphragm, they have got a common origin. Developmentally, they originate from the septum transversum. ঠিক আছে, এটা জাস্ট মনে রাখো. So the cavity enclosed by the fibrous pericardium, and within which we are getting the serous pericardium, and inside which we are getting the heart. So this area actually divides the inferior mediastinum into anterior, medial and posterior mediastinum. The heart itself, along with its pericardium, actually resides within the middle mediastinum. Okay, so this is anterior, so inferior mediastinum is divided into anterior mediastinum in front of the heart and the body of the body and the G5 process of the sternum. This is the anterior mediastinum. The fibrous pericardium enclosed the area is the middle mediastinum, and the area behind the fibrous pericardium, or this is the base of the heart. Okay, this is also called the base of the heart. The posterior surface or the base of the heart is which is bounded in front by the base of the heart in front and behind by this T5 to T12 vertebra. This area is called the posterior mediastinum. So, mediastinum is a space which is enclosed within the two mediastinal pleura, which is divided into superior and inferior mediastinum. Plane is passing, the plane of division is by the plane which is passing through the sternal angle, and below the T4 vertebra. Superior mediastinum divides into superior mediastinum and inferior mediastinum, and heart itself divides, heart with the pericardium divides the inferior mediastinum into anterior, medial and the posterior mediastinum. Now, in the superior mediastinum, what are the structures we will get? Most in front, we will get one vein, great vein, that is formation of superior vena cava. Okay, formation of the superior vena cava. Actually, superior vena cava is formed by, we know, left and right brachiocephalic vein, and this brachiocephalic vein is again formed by, one vein is coming from the head region, that is the internal jugular vein. Another vein is superficially we can find, that is the external jugular vein. These two, internal jugular and external jugular vein, ultimately we will get a vein. Okay, that vein will join with the subclavian vein from the extremity. Okay, so this internal jugular vein, okay, and this subclavian vein will form the brachiocephalic vein, and these two brachiocephalic vein will join and will form the superior vena cava. Okay, now we can find the formation of superior vena cava here. Okay, and also we get the part of the superior vena cava most superficially. Then we will get the different branches of arch of aorta. We can find 3 branches. Okay, that from right to left, we can say that is the brachiocephalic trunk, left common carotid artery and left subclavian artery. Okay, and this height of the arch of the aorta will reach up to the middle of the manubrium sterni. Clear? So, most superficially we will get the veins, right cephalic vein, left cephalic vein, and formation of the superior vena cava. And this superior vena cava will ultimately pierce the fibrous pericardium and ultimately the serous pericardium, and it will open into the right heart or right atrium. Okay, so it has got intrapericardial and extrapericardial part. Okay, and at the junction of intra and extrapericardial part, we will see in the cadaver, that is the drainage of the azygous vein. Okay, we will see. So these are the structures we will find from front to behind, and most behind we will get two pipes. One is windpipe, okay, that is the trachea in front, and another foot pipe or esophagus, and in between we will get one nerve in between. We will get one nerve, that is recurrent laryngeal nerve. The groove between the trachea and esophagus, within the groove we will get the recurrent laryngeal nerve. Okay. What are the other structures we will find here? One is one is in front, that is on a anterior plane, one nerve will come down. This is the phrenic nerve, and another nerve on a posterior plane which will come down as a vagus nerve. Both right side and the left side. Right on the right side, right vagus, right phrenic, and the left side, left vagus and left phrenic. Always remember, phrenic nerve is in front of the root of the lung. We will find the phrenic nerve in front of the root of the lung and vagus nerve behind the root of the lung. Okay. So, vessels, I have already said, superior vena cava and arch of the aorta. It will start at the level of the sternal angle and it will end, or it will start at the sternal angle and it will end in the sternal angle. Okay, and it will be continued as a descending thoracic aorta. Okay, so it will continue as a, it will continue in the descending thoracic aorta. Okay. So, and what are the other structures we can find? Most anteriorly we can find another structure, one gland which is present in a childhood period, that is the thymus gland, and which ultimately involutes in adult. We can hardly find any gland, thymus gland in adult. Okay, so thymus gland, we can, the retrosternal gland, that is the thymus gland. And what are the other structures we can find within the superior mediastinum? We can also find some areolus tissue, some lymph nodes behind the sternal group of lymph nodes, okay, within this space. And also in front of the trachea, we can find pretracheal and paratracheal group of lymph nodes. Now, in the inferior mediastinum, this is the anterior mediastinum. This anterior mediastinum, what are the structures we can find? We can find there are two ligaments from sternum to pericardium, fibrous pericardium. One is superior, one is inferior. They are called superior and inferior sternopericardial ligaments. Superior and inferior sternopericardial ligaments. And also behind the, just behind the sternum, we can find the prolongation of the thymus gland, retrosternal lymph nodes, and also one very important artery. Okay, that one very important artery will come down, that is the internal thoracic artery. Okay, just behind the sternum on the parasternal region. Okay, we can find internal thoracic artery. Okay, it is coming from the subclavian artery. Okay, subclavian means we know brachiocephalic, left common carotid, left subclavian. Okay, there are three branches from the arch of the aorta. From the subclavian artery, it will come out. Okay, from the first part of the subclavian artery, this artery will come down, and ultimately it will divide into superior. We have already seen in the rectus sheath. Behind the rectus sheath, we have seen two arteries, superior and inferior epigastric artery. So it will divide into superior epigastric artery, and one will go laterally, that is the musculophrenic. Okay. So internal thoracic artery we will get in this space, and also some lymph nodes, and also that which are retrosternal lymph nodes, and also some areolar tissue. And within the mediastinum, we are getting the heart. Okay, and with its great vessels. That means pulmonary trunk and the arch of aorta, or ascending aorta. Okay, ascending aorta and the pulmonary trunks we will get. Okay. Now in the posterior mediastinum, what we will get? First, what is the boundary of the posterior mediastinum? Behind by these vertebrae, T5 to T12 vertebrae. In front by the base of the heart, and also by the bifurcation of the trachea. We know bifurcation of the trachea is at the sternal angle. It divides into right and left bronchus. Right bronchus is more vertical than the left bronchus. So any object, okay, any foreign object can easily enter into the right bronchus. Okay. So this is the, so in front the boundary is the bifurcation of the trachea, base of the heart. Actually this is covered by the fibrous pericardium, and also by the upper part of the upper arch. This is the, we can see this is the arch part of the diaphragm. So this forms the anterior boundary, and this is the posterior boundary. And what are the structures we will get? We can see these bronchus, okay, which are entering inside the hilum of the lung, respective lung, okay. And also we are getting the food pipe or the esophagus, okay. We will get the esophagus. At the same time, we will get the descending thoracic aorta. Okay. Now, this esophagus, actually esophagus will cross the descending thoracic aorta. Actually, esophagus first remains on the left side. It gives an impression over the apex of the lung. Then it deviates to the right side, okay, and goes from T5 to T9, it goes down straight, and at the T9 level it crosses the arch of it crosses the descending thoracic aorta, and it goes towards the right side. So left side. So first it remains in the left side, then it goes towards the right side, or in the midline, then again goes to the left side. So left, right, left. So esophagus first remains on the left side, okay, gives an impression of we can see the mediastinal surface of the lung. Within the mediastinal surface of the lung, we will get an impression. Then it deviates towards the right side, left, right, goes down, then again goes to the left side. Again we will get an impression over the mediastinal surface of the left lung. So remember, esophageal impression over the mediastinal surface of the lung, we will get twice. One at the above the hilum, below the hilum. Okay, because esophagus first remains on the left side, then shifts to the right side, again goes to the left side and crosses the descending thoracic aorta at the level of T9 vertebra. So this is about esophagus. And behind the esophagus, we know one channel goes up. Lymphatic channel goes up. We start from the abdomen. We know there is dilated lymphatic sac, which is called the cisterna chyli. Okay, from here this channel actually starts, which is called the thoracic duct. We must know the lymphatic of the whole of the body. Remember, lymphatics of the whole of our body, except the right side of the face and neck, right side of the thorax, heart, right lung, and right lobe of the liver, and right half of the dome of the diaphragm, except all the parts of the body, and the lymphatics from all the parts of the body, they drains into this thoracic duct. Okay, so thoracic duct is just behind the esophagus. It goes just in front of the vertebra, and in between vertebra and the esophagus it goes up, and at the level of T4 it shifts to the left side, and ultimately it makes an arch at the level of C7 vertebra and drains at the junction of internal jugular and left internal jugular and left subclavian artery. So it will drain there at the junction between the left internal jugular vein and the left subclavian vein. Okay, so that is the thoracic duct. We will get the thoracic duct. Any other thing? Yes, we will get from the head onwards one sympathetic and parasympathetic nerves are coming down. The sympathetic chains are coming down. They will pass and they will occupy that sympathetic chain, one on the right side, one on the left side. They will occupy the posterior mediastinum, and from this sympathetic chain, the several three nerves which are called the thoracic splanchnic nerve, which will pass medially, and also they will occupy the posterior mediastinum. What are the other structure? That is the descending thoracic aorta. It will also remain in the posterior mediastinum, and also the posterior intercostal veins, posterior intercostal arteries, we will get in this posterior mediastinum, or posterior, rather on the posterior thoracic wall. Okay, so these are the things. So now we can go to the cadaver, we can find out the different structures in the mediastinum. Okay.